Good morning, everyone. So, welcome to this week 5. We are now halfway through this course of clinical management of HIV. So, I think all of you are up to the pace of like submitting the assignments and homeworks and quizzes and all that. So, this has been great up till now. The participation and the fallout was very less, fortunately, this time. And it's great that we all are keeping up to the pace. So this is week 5, and in this week, the topic for this week is partially what we already know and follow. Most of us we know the details of it, like post-exposure prophylaxis, but pre-exposure prophylaxis is something which is not there in the program, but many of us are aware about it, and this will be a kind of good revision this week, and also HIV as prevention. And as I've been telling since beginning that in this course we actually review the evidences behind certain strategies which are guidelines which are being used widely across across India and also across the world. So the two lectures conducted by the UDO faculties, Dr. Brian and Dr. Dana Reddy, those were quite comprehensive in talking about these two topics, and especially those evidences which are very essential basics to understand the concepts. So it's very good referral document, and also I'm sure that you might have seen that. If not, please go through the two lectures. And the last date of the next of the assignment for this session or this week is next Sunday, which is, I think, is it 12th of May? Yeah, it is 12th of May. So please complete your quizzes before that. And as far as homework assignments are concerned, they don't have usually deadlines as such, but they will be open. So as soon as the week is over, please submit those as well. So let's start with the this week's session. Like every week, what I've done this time also, I've taken slides from NACO training program for post-exposure prophylaxis. But HIV prevention and pre-exposure prophylaxis, there are very few from NACO, and in fact for pre-exposure prophylaxis there are no, that is not part of our program, and that is why it is not there in the training curriculum also, so I have not taken anything. But as just to brief you about what is happening with NACO on pre-exposure prophylaxis, officially there is no document as such where the approval for pre-exposure prophylaxis has not been approved as of now, but discussions are still on in NACO, and as far as I know or I understand, there is no denial for pre-exposure prophylaxis, at least. That's my personal understanding. I'm not making any official comments. So sooner or later, and also I've heard that there is actually some kind of basic agreement also, but it has not been officially approved, the pre-exposure prophylaxis things, but it may come in the program in future with quote unquote like specific use and about with all those specifics of the guidelines and everything. HIV prevention or treatment as prevention, especially, we are already doing that. Some may know about it, some may not know, but already the treat all strategy is something which is very important for prevention, one of the very important preventive strategy actually. So we are already doing that. So when Dr. Dhani Reddy talked about prevention as ART as prevention, so that explains the basis of like from where it is coming from and how it is good to use. So I think then for those who are working in the program since long time, pre-exposure prophylaxis will be something which is good to go through. And post-exposure prophylaxis, there are few changes in the guidelines. For those who do not know about it, obviously we did many NDLS also on this before. It's there in the guideline document as well. So let's see all that, and if you have any comments and discussion point, you can just type over so that I can read through. So what is PrEP or pre-exposure prophylaxis, and how does it work? This is kind of revision which has already been told by Dr. Brian in his lecture, which is already there on the canvas. I'm just revising it just to reinforce a few things. So it's a preventive strategy basically, but again it cannot be a standalone strategy. So if, as the name suggests, it is a preventive strategy before the exposure has happened. But it cannot be a standalone strategy, and no one recommends that if someone is taking pre-ART drugs or ART or pre-exposure prophylaxis, they are completely safe of HIV infection. So these 3-4 highlighted things are really important to know. That is, it is preventive strategy in which a high-risk individual takes medications regularly along with behavioral risk reduction strategies to prevent HIV infection. First of all, it is not given to anyone and everyone just for the fear of HIV. It is effective if it is given to high-risk individual who takes the medications regularly. And we'll talk about the adherence, how much it is required for this successful prophylaxis with this strategy. But along with that, no one says that if you are taking this medicine, you are safe of HIV, so you need not use condoms or any other risk reduction strategies. So it has to be used along with behavioral risk reduction strategies. So in a way, it is one of the additional risk reduction strategy in addition to the existing behavioral risk reduction methods, which we already recommend even in our program. Like condom promotion is one of the most important prevention strategy, in addition to treat all these days. So the only drug which has been approved till now for this is Truvada, by this brand name Truvada, tenofovir emtricitabine combination, TDF and emtricitabine combination, tenofovir disoproxil fumarate and emtricitabine combination. Even the generic has not been recommended by many, so only Truvada has been said. I actually didn't understand why generic were not recommended and why only Truvada, but that was said. So this is the only drug which has been approved till now, but as Dr. Brian mentioned in his lecture, in next 6 months we hope that even tenofovir alafenamide and with the combination of emtricitabine may get the approval. So he included those slides also in his presentation. He presented these evidences to make a point about the estimated protection from pre-exposure prophylaxis. So for all patients, out of these 5 studies, in 3 studies at least, you can see like from 44 to 75% protection. Partners PrEP study, that is in serodiscordant couples. Then TDF2, that is in heterosexual men and women, and ITECH, which is for men who have sex with men. So the protection of HIV because of pre-exposure prophylaxis, the range was very wide. In the lower 2 studies which he presented, which were done both in women, the main problem was adherence. As adherence to these drugs was not good, the ultimate outcome was very bad. So it is not. It just says that in addition to like routine adherence reinforcement strategies, there are other barriers. If there are any gender-related barriers, those also need to be addressed. Like it's comparatively, it may not be easy for women to be on this kind of treatment, and as compared to men. So in those 2 studies, adherence was a big problem, but in other studies, it was like from 44 to 75%, and that was in all patients. But if you say in good or adherent patients, this was the scenario: 90%, 78%, and 92%. And obviously in women, adherence was not good, so that was the thing. So it's very clear that if adherence is good, efficacy of the pre-exposure prophylaxis is better. And that's how Dr. Brand explained with the help of this graph, efficacy versus adherence. So these are different studies with different success rates. In Proud study, you can see like 100% or 86% protection. He also actually displayed a poll asking for like how much, what do you think will be like protection rates because of post pre-exposure prophylaxis, and then he said like 80 to 90% is can be the most appropriate answer. The main reason he said why it cannot be 100% is because of, and one of the main reasons for that is if someone is infected with the virus which is already resistant to these drugs, obviously that will not work against those viruses, and that may be one of the reasons, and that has happened actually. He also presented the cases which were actually regular on pre-exposure prophylaxis and still they got HIV, and when their genotyping was done, it was found to be having multiple mutations. There was a table which was displayed by him, which we can also see. So he also presented the US scenario regarding pre-exposure prophylaxis, and it may apply here as well. There is a good news and there is a bad news. Good news is if someone markets post pre-exposure prophylaxis, HIV diagnosis is expected to increase because people may come forward for this particular intervention if they know about it. So HIV diagnosis overall have increased. HIV diagnosis overall have decreased, and increasing use of PrEP is likely to be one of the reasons. So one of the reasons of ART treatment may be increase in diagnosis, but number of testing I mean to say, but as far as number of diagnosis is concerned, it has overall has gone down. That was happened in US. But bad news is many who need PrEP are still not receiving it. So there again, availability and accessibility to the treatment may be an issue, and which is true here as also. Now please understand that even though it is not there, pre-exposure prophylaxis in the program, still it's not in the private setup or in the community. It's not that it is not known to the people. So at least some of them are aware about it. I'm not talking about the majority and those who are like or all people of the community, but at least there has been some kind of advocacy of pre-exposure prophylaxis. It has been piloted also at some of the places, but because of, we need to understand the I think the way the epidemic is here in India. We say that it is concentrated epidemic, so but the people whom we are treating in our ART centers are even from general population also. So to identify those who are at risk and provide some kind of intervention like this in those patients. So it may not be useful if the risk is not high. If there is low risk, it may not be useful, or it is not recommended, I would say. And if the risk is high, in those again problems of adherence and those things, stigma and those things might come. So as evidence from US, what he presented was that HIV has gone down because of pre-exposure prophylaxis, and but the accessibility is not that straightforward. So there are many concerns around pre-exposure prophylaxis. That's what they did some kind of study in the providers, so about the awareness of pre-exposure prophylaxis, and they got to know that people, almost like 65% of the people, they had heard about PrEP, and 35% did not hear about PrEP. And those who heard about PrEP, their main concern were adherence and costs. So as what will be the adherence, and obviously people like us who are already treating many HIV positives, we understand that how difficult it is to maintain the adherence even in HIV positives. Here we are talking about giving a drug to someone who is HIV negative to prevent HIV. So obviously we all will be concerned about adherence. And we have just seen in those two studies in women, if adherence is not good, what will happen to pre-exposure prophylaxis? The failure rates will be very high. And cost is, of course, because here the intervention cannot be like for few days. It will be for weeks together. So at the patient level or the client level, the reasons for not, or these are the concerns or the reasons for not using PrEP, and the most common reasons were these two, like concerns about costs and concerns about potential side effects of the drugs, and again they didn't know where to get this PrEP from. But there are others also, like do not feel at risk and concerned about potential effects on insurance, which may not be applicable here. I don't think it would be effective. So concerned about reaction of the sexual partner. This is another thing which may be a barrier, and that if the partners may think that the person who is taking PrEP is already having HIV and taking some kind of treatment for that, may not understand what PrEP is. So obviously that may be one kind of stigma the clients will be facing. So these are the concerns at the level of the clients. What about the side effects and safety profile? Like any other treatment, this also will have some kind of startup syndrome. In trials, nausea and were common in with this combination than the placebo, nausea, headache, and fatigue. So these are like any kind of treatment. So patients may feel some kind of side effects in the beginning, but once they are stable on that, later on it actually subsides. Now, whenever tenofovir is used, we always think about renal toxicity, and we sometimes are very concerned about it. But in trials, what they have shown is changes in renal function are not more frequent with this than placebo. So one reason for that can be because this is being given to those people who are healthy, those who are physically active, healthy, without any problem. As against in HIV positive, we are giving treatment or TDF to a person who is actually sick and who may have some other issues also, may have some pre-existing renal issues as well. So there we see more side effects than as compared to those who are HIV negative. So giving a drug in a healthy person, you may not come across those many side effects, and that's what they observed. Similarly, bone marrow effects in trials, TDF and that's true are the same combination associated with small change, about 1% in bone density through generally stabilized or improved, no increase in fractures seen. So these are the two side effects which we usually are worried about whenever we use TDF. But using TDF for an HIV positive and those who are HIV negative may be different. We may see more toxicities in PLHIVs, and if we use for the prevention, we may see less of them. So these were the patients actually. These were the only 6 patient-related data for those who were actually adherent to PrEP, and still there was a failure which was reported. So if you remember last week we spoke about mutations and all that. So these are all thymidine analog mutations, and also M184V for lamivudine and K65R for tenofovir. And so all these mutations you can see here, so which says that the virus which was actually with which the people were infected, maybe that virus was resistant virus. So that will be one of the reasons. About STI and HIV, now this was one concern that whenever we have spoken about STI in the past, we always STI put together with HIV, because the prevention strategies which we recommend are almost all similar for STI prevention and HIV prevention. So when this particular strategy will be rolled out, or we use this strategy, then I think there will be a need for dissociation between these two prevention strategies. All the other things we can talk about STI and HIV together, like condom use and those things. But for pre-exposure prophylaxis, it will be different from managing STI. So what they have seen in various studies was high STI incidence among MSM who used PrEP. That means they might have, the use of condoms might have gone down, but some of the studies there no difference has been seen in immediate and deferred arms. About patients' perspective, patients may have, because of all this advocacy, people know about HIV, and even those who are indulging in high risk behaviors, somewhere they are also concerned about acquiring HIV infection, even though they may or may not say it out loudly, but they may have these concerns. So because of this PrEP, those who are at risk or those who are at high risk, they may feel decreased anxiety, increased communication or disclosure, increased intimacy or trust, increased sense of community, and increased self-efficacy. And this was actually documented by the study when the source was given. So this is what PrEP offers to the patients. So who should be the target for PrEP and how it is prescribed? So who should be given? So CDC came up with this guideline in 2014 and it was updated in 2017. So this is not an exhaustive list, and this is not the only list. These are some of the examples. One thing is sure, that it is to be given those who are at high risk or substantial risk of HIV. It is not for anyone and everyone. Who can be those? Those who are in a sexual relationship with someone who has HIV, for example, the serodiscordant couple, if we can talk about. So those will be good targets. Then MSM not in a mutually monogamous relationship and not using condoms, and 100%. Obviously, those who are having partners or more than one partner, and those who are not using condoms. Then recent STIs, which means condoms are not being used and they are at risk of HIV in last 6 months, and person who inject drugs, PWIDs. Now this has been again we'll come to that discussion about people who inject drugs, or IDUs we call them in the program. So they obviously have the risk of HIV acquisition. So then serodiscordant couple who want to conceive. This is one scenario which I think is many of us might have come across, especially in serodiscordant couple. They might come to you and say that they want to conceive, and if there is any kind of protection, because if suppose man is positive, or in the serodiscordant couple, if male is positive and female is negative, then if they want to conceive, obviously the risk of HIV will be to the woman, and then and that can be prevented in a sense. So we might have come across these scenarios, and if people might be asking to you also that what will be the good time and how it can be done in a safer way. Then recurrent need for post-exposure prophylaxis. So those who obviously in our country we are giving post-exposure prophylaxis only for occupational exposures, but those who give it for the sexual exposures also, and those and PEP, post-exposure prophylaxis, can be used for those reasons, like ruptured condoms or even sexual exposure for sex without condoms, and things like that. And for which, if a person has already taken post-exposure prophylaxis but again indulge in high-risk behavior and again comes back, so recurrent need for post-exposure prophylaxis can be one in the list. There is a comment. I think in our national program, PrEP should be provided to serodiscordant couple who want to conceive. Yes, that might come in future. Like I said, there is no denial for post-exposure prophylaxis, and the program focuses on very specific things. And I agree with you, and let's discuss that also in few slides. So The guidelines for prescribing PrEP: first is determine eligibility to confirm whether the person is at substantial ongoing risk for HIV or not. Then able to take a pill every day and return every 3 months. That is about adherence. Then screen for HIV and consider need for HIV viral load, and check hepatitis B antibody panel and renal functions. For prescription of PrEP, as I mentioned, there is only one FDA approved drug till now, that is Truvada, one tablet orally every day, no more than 90 days at a time. So at the most they can prescribe 3 months drug, then emphasize importance of adherence. Okay, someone is not able to see this slide from Raipur. I hope others can see the slide. Okay, so I think ART Center Raipur, you can check your connection. There's no problem from this side. Continue counseling, continue risk reduction counseling and other preventive measures. That's what we were talking about since beginning, that it cannot be a standalone strategy. The other preventive methods should go on along with pre-exposure prophylaxis. Lab monitoring every 3 months, HIV tests need to be done every 3 to 6 months, STI screening every 3 months for MSM it need to be done, and renal functions at 3 months, and then every 3 to 6 months. So these are the tests, that's what we spoke about, which are recommended. As we are using TDF, we recommend like creatinine, serum creatinine after 6 months, and then but if creatinine clearance is less than 60, PrEP should be avoided. So the main challenge has been taking this drug every day for a longer period of time. Like Dr. Dhelan mentions, in IDU, PrEP adherence can be a big problem. Not only in IDUs, I would say that in anyone who is HIV negative, PrEP adherence is not that easy unless people are concerned enough and understand enough about the risk of HIV and they want to prevent it, and so obviously it's an option, and adherence will be a problem. So these are the questions which are yet to be answered. What is the role of intermittent dosing? If I don't want to take it every day, can I take it like alternate day or intermittent dosing, or like 3 days a week or so? Then how soon after a person starts PrEP is protective? For example, we spoke about that serodiscordant couple. If that couple comes to you and you end up in starting PrEP for those patients, I'm not saying in the program, I'm just saying like just a scenario. So what will be the advice? Like, when can they have sex without condoms for like just to conceive? So when should they start, or when should the negative partner start PrEP? So that duration. Then how effective are other drugs besides tenofovir and abacavir, like other than Truvada, if there is any other drug? So what are the benefits of individuals whose partners has HIV with suppressed viral load? We are talking about U is equal to U, that is undetectable is equal to untransmissible. So those who are having viral load of less than 200, anyhow we are saying that HIV is not getting transmitted. So is the negative partner or recommended to take the PrEP in that scenario? So is tenofovir alafenamide is effective for PrEP? Is there any safe option for a person who have kidney disease? So let's discuss few of these. In Dr. Bryan's session, he has discussed all these things in detail. That's why I recommend like all of you to listen to those 2 lectures, those who have not gone through them yet. So now about the intermittent dose or on-demand dose, like pre-sex or post-sex or things like that. CDC has clearly said that don't do it, but other guidelines may have said that it can be used as an alternative way of prevention. So the 2 studies which Dr. Bryan discussed in his sessions, one was this IPERGAY and in which he talked about this randomized controlled trial in which 199 in study arm the clients were enrolled and compared to 201 in placebo arm in 86% reduction in HIV incidence. Obviously, this is not this was kind of a review of records. Those who did take and those who this was a randomized control trial basically, and the other study was non-randomized prospective cohort, and 86% reduction and zero HIV infection in either arm. So this is like the strategy of using 2 Truvada tablets before sex and then 2 in 48 hours after sex. This was used, and which actually resulted in 86% reduction, and that is why other guidelines say it can be an alternative strategy, but CDC guidelines have said not to use it. About the timing, how soon that effective levels can be reached. Now, in the rectal tissues, the effective levels of the daily oral dose, the maximum intracellular concentration with daily oral dose of Truvada in rectal tissue 7 days and cervico-vaginal tissue it is 20 days. But again, these levels are effective maximum intracellular concentration, that is MICs. It is not that like preventive concentration. It may reach even before that as well. I'm trying to just explain that there is a difference between MIC and also that is the effective concentration to prevent HIV infection, which may reach before that. But if someone asks you when the PrEP should be started, so it should be at least like 3 weeks. So 7 days to 3 weeks it takes to have that MIC. So if discontinuing, continue for 28 days after last sex. So this is what has been recommended in CDC guidelines. IS-USA guideline, they just said 1 week lead-in time recommended, but they have not given the reasons and percentages like where and what and all those details. So, and discontinuation also they say continue for 1 week after last sex. So this looks like personally I feel more comfortable with this, like pre-exposure, like 20 days before the exposure and 28 days after the last sex. So this was another study which he discussed in great details about the newer formulations of tenofovir, that is tenofovir alafenamide versus TDF, if alafenamide can be used. So what it was concluded in this study was again tenofovir FTC stands for emtricitabine. So tenofovir alafenamide and FTC combination, it is non-inferior to TDF and FTC concentration for PrEP in high risk MSM and transgender women. So both drugs were well tolerated, but bone and renal outcomes were favored obviously in TAF. High risk individuals behavior constant with no evidence of compensation. But the concerns are limited follow-up in this and no participant with renal dysfunction and generalizability to all. So Dr. Brian was really hoping that in next week, 6 months, this might get approval, but these are the concerns. These are the concerns which FDA might review. So, okay, is there any question? Does entry inhibitors have any role in intermittent PrEP? As I said, there is no other drug which has been said to have any role in PrEP as of now. And it has not been recommended other than Truvada. That is the only drug which has been recommended. For discordant couple, how many days before PrEP should be started? Yeah, so that's what we saw, the difference between the two guidelines. As CDC recommends, and as Dr. Dillon mentioned, we can start at least before 7 days and to 3 weeks. So we spoke about this at least 3 weeks before the sex and to be continued for 28 days after the sex. And but other guidelines recommend 1 week and 1 week also. So that's how it is. But again, this is if we are talking about PrEP as a standalone. But one question that we already raised before, PrEP in patients who are already having a partner who is having HIV suppressed, where we, on one hand, we are saying that U is equal to U, undetectable is equal to untransmissible. If undetectable is untransmissible, then why to give PrEP in people who are partners of these people who are having suppressed viral load? So again, there is no one can be no one knows the answer as of now. At a larger community level, I would say it is good to give that message: undetectable is equal to untransmissible, and there is enough evidence for that. We'll see that also in Dr. Dhani Reddy's lecture. We already saw that she presented those evidences, how how it works. So, and it is definitely right now well accepted fact that for sexual exposures, if someone's viral load is undetectable, which is not less than 1000, that is called a suppressed viral load by definition. Undetectable is less than like TND, you can say. So that is not transmissible. So in those patients, if you come across a serodiscordant couple and a positive partner has a TND viral load, then if the negative partner does not have any risk of PrEP, risk of HIV, then should we give PrEP to that line? Now that no one answers that question, but obviously if someone wants to take, you can give in those patients. So what is it in future? Obviously people will require some kind of sustained release or some kind of easier, as adherence is a challenge. That's what we saw. So people may want newer options. Vaginal ring is one thing which has already been tried, but again, that is it was not that easy for the women also, and also for their clients it was, and partners it was not. Someone were actually even discriminated because of using the vaginal rings. And then for injectables, there is an injectable formulation which is again in trial for PrEP, injectable cabotegravir. So injectable cabotegravir, now this is a formulation which is being compared to daily TDF and 3TC for PrEP. It is considered to be it's a long acting drug. So, but again, there is nothing much known about the results and those studies. But whenever it comes, we would know about it. So, about the adherence, again, when we say that adherence is so important, then different methods for adherence can be used to improve the adherence. So, overall, if you see in this lecture, there are few like takeaways for us. One thing is, for in our program, as I said, there is no denial for PrEP. It may come in future. It may come in very near future for those people who are at high risk. But there are many caveats to it, like how it is to be used, how important it is to identify those appropriate clients for its use. It may come again for a serodiscordant couple, but right now what we have is again one of the best options we have to have a suppressed viral load. So I would recommend, if someone comes to me to as a serodiscordant couple for having kids, so having a viral load test for the positive partner, and if whenever the viral load is undetectable or target not detected, that will be the right time for them to have sex and conceive. Earlier we used to advise the other methods, and even now we may advise like sperm washing and IUI and IVF. They said that it is very expensive. IVF may be expensive, but IUI, intrauterine insemination, and sperm washing, at least in our country, it is not that expensive. It's a few thousands. So those who plan to do can go for that as well. But PrEP, as it is not there in the program, we are not using them at the ART centers at least. That can be one of the options outside. Okay. So Dr. Harshad is not able to see the video. He says it is disrupt. If it is not the case with the others, I think Dr. Harshad can reconnect um, and see again if there is any problem with your internet connection. Okay, so efficacy and preventing HIV is high. So though not 100%, so should be combined with ongoing risk reduction strategies. Adherence is a key, and remember to ask about risk behavior, think about HIV risk, and discuss PrEP. So obviously this is an option, but it comes with all these things as a package. So we should know about all these things and the evidences behind it. We should not make any hurry in making any decision for starting PrEP to anyone. So all these things need to be considered, but together with other preventive strategies, it is obviously one of the good strategies. In presence of treat-all, however, if the positive partner have undetectable viral load, then role of PrEP has not been explained. No one knows how to explain that. So, but that is one thing which need to be thought about before prescribing PrEP. Then the next thing was post-exposure prophylaxis, which we are already aware of. So it will be kind of revision for many of us. So in post-exposure prophylaxis, we are concerned about. Okay, before that there is a question. Please share some data regarding that other options we have for patients who are serodiscordant couple who want to conceive. We have been actually telling or advising our patients about sperm washing. If the male is HIV positive and the woman is HIV negative, we say that sperm washing is an option where in the lab they wash the sperms, and which is because HIV is in seminal fluids, and that is how it get rid of it, and they use only sperms for like conception. And intrauterine insemination is where there is like artificial insemination in uterus is done with the help of a syringe. And in vitro fertilization, there are many methods. Right now there is XC and like intracellular, they directly. There are many things in that area. Also IVF, there are many advances, but IVF is expensive and it requires a lot of preparations and everything. It may not be that easy for HIV positive to undergo all these things, but options are there. But one of the easiest options, I think, is again ART. So you should stress that again and again, ART, and whenever they want to conceive, they should know the viral load of HIV positive, and if that is undetectable, then the risk is very, very, very low. So, and to the extent that now everyone talks about undetectable is equal to untransmissible. Okay, so post-exposure prophylaxis. In exposure, how the exposure has happened, or if it is a percutaneous injury like needle stick injury, contact with mucous membrane, contact with non-intact skin, that is skin which has some kind of injury, and contact with intact skin. So this all the exposure, occupational exposures. First of all, we give in our program to the PEP or post-exposure prophylaxis only for the occupational exposure, and only for those who are rape victims. So in our guidelines for the rape victims also, it is a part of the package in which rape victims are offered post-exposure prophylaxis. So occupational exposure refers to exposure of potential bloodborne pathogens like HIV, HBV, HCV that occurs during performance of a job duty. Like for example, doctors, nurses, lab technicians, and those who work in the hospital, or the sweepers or ward boys, and those people, and janitors. So wherever they work in a hospital setup, and if they get the exposure, it is called as occupational exposure. Non-occupational exposure refers to the exposure to these potential bloodborne infections outside the workplace, like unsafe sex or sexual assault. And post-exposure prophylaxis refers to a comprehensive management instituted to minimize the risk of infection following potential exposure to bloodborne pathogen. It is not just the drugs or tablets, it is in fact more than that. So I'm not going in definitions of occupational exposure like needle stick injuries, exposed person and source person, but just to tell it broadly, needle stick injury, all of us know, there is a difference between the way a PWID, people who inject drugs, take the drugs, and a needle stick injury. Usually we are scared about needle stick injury because of so one of the reasons is like we see high prevalence of HIV in IDUs. See, IDUs, they take, or the PWIDs, they inject the blood, the needle in their veins, and they take withdraw some blood just to ensure that the needle is in the vein. Then they push the drug inside, and if they share the same needle with the other guy, and he or she also will do the same thing. So here we are actually, they are taking blood in the syringe and injecting the same blood in other person's body. That is why the risk is really very high. Needle stick injuries are not like that. It is usually, it's a kind of it depends on many factors. We'll see those. Exposed person to whom the exposure has happened, source person, that from source person is who is the possible source of contamination of that particular body fluid. So if a needle which was actually pricked to an HIV positive person, and that needle gets pricked to the other person, so source is here HIV positive. Who is at risk? Nursing staff, students, emergency care providers, intern medical students, labor and delivery room personnel, surgeons and of the operation theatre, lab technicians, dentists, physicians, and others. Basically those who work in the hospitals. 0.67 risk in IDUs. Again, but if you see the prevalence of positivity in IDUs, it is really high. So it all depends on the risk or the prevalence of that particular disease in that particular population. The risk of exposure because of needle stick injuries, it may be like 0.3%. In IDUs, it is more than that, like 0.67. But again, what I would say is some of the places like Mizoram and Northeast, you would see like in some of the groups, the prevalence of HIV is almost like 25% of the IDUs, 30% of the IDUs are HIV positives. So it becomes really difficult again to say that risk is very not high. So you get like very easy spread of HIV in those particular categories of the patients. But for needle stick injuries, it is really low. That I couldn't really say. It is just 0.7. The 7% of the prevalence is the national prevalence. So again, there is a difference. If you see the local prevalence at different places, it is again different, right? Yeah, but you're right. Like this is 7 to 8% is the national level prevalence, but state-wise, if you go, so there the prevalence in IDUs is really high. Like I said, some places is 25, 30%, and even more than that as well. Risk of exposure to body fluid considered who are at risk. So these blood, semen, vaginal secretions, synovial, pleural, peritoneal, amniotic fluid, pericardial fluid, all are considered to be potentially infectious. These other fluids like tears, sweat, urine, feces, saliva, sputum, vomitus, they are considered to be non-infectious unless they are stained with the visible blood. So average risk of acquiring HIV in Hep B, Hep C, if you compare this risk of acquiring HIV because of percutaneous injury of HIV, it is 0.3%, HBV is 30%, HCV is 1 to 1.8%. But just to remember, easily you can say 0.3, 3 and 30. 0.3 is HIV, 3 is HCV, and 30% is HBV. That means HBV is still more and more infectious. And good thing about HBV is we already have vaccine for that. So someone who is not vaccinated should get themselves vaccinated, especially if you are working in the hospitals. I think it's good to get vaccinated for HBV. Mucous membrane exposure, it is 0.09, which is very low. Then HIV transmission risk by different routes. This slide we have discussed before as well. That blood transfusion, peritoneal is maximum, and then risk reduces with the other. Because of sexual route, it is 0.1 to 10%, but the needle stick exposure, if you see, it is 0.67, and IDU it is 0.67, 0.3 and 0.67. So how does the needle stick injury happens? The most common reason, if you see here, is like 27% is while actually recapping the needles. So the recapping is something which should always be avoided, and that is the most common, actually, the reason for needle stick injuries. So whoever is using the needle should not recap them. And how do we manage that? So for management, first step is again the management of the exposed site with the first aid. Then establish eligibility for PEP, whether the person is eligible for giving PEP or not. Then counseling for PEP. Then assessing need for PEP and prescribing PEP. Lab evaluation, follow-up of an exposed person. For skin and eye and mouth, there are again few slides. So for skin, whenever the exposure has happened to the skin, only it should be immediately washed with first step is actually to maintain the calm, and it's difficult. I understand that in that particular scenario, but we need to train ourselves in that way, that if that happens, because if we are not stable, we'll not be able to take right steps. So immediately we need to wash the area with soap and water. We should not be scrubbing it and applying any kind of antiseptic to it, just to make sure that we don't cause any kind of trauma to the skin, like in the form of abrasions and things like that. And do not put the finger into the mouth. Usually that is a reflex, but that should be avoided. So all the effort should be taken to avoid further damage at the site. In the eye, obviously we will not put the soap in the eye, so it has to be just irrigated with the water, and this is how it need to be done. Sit in the chair, tilt the head back, and ask the colleague to gently pour the water or normal saline over the eye. If wearing contact glasses, leave them in place at that time. Don't try to remove them, because again, while removing, you may cause some kind of injury, and again that might be a portal for entry for HIV. So leave them in the place, as they form a barrier over the eye and will actually help to protect it. Once the eye is clean, remove the contact lens and clean them in the normal manner. This will make them safe to wear it again. Do not use any soap or disinfectant. For mouth, just rinse it, spit the fluid out immediately, rinse the mouth thoroughly using water and saline, spit it again several times. Do not use soap again to disinfect. Consult a designated physician for reporting the exposure. So it actually depends on the exposure. It may be mild, moderate, or severe. Mild is exposure to mucous membrane, like suppose you are doing some kind of pleural tapping and the tube get disconnected from the middle and there is a splash of the fluid to your eyes. That is kind of mucous membrane exposure. Or you are attending a labor and somehow you are not using the protective gears and the fluid, you are exposed with the fluid because the amniotic fluid comes out with a gush, and if that if mucous membranes are exposed. Moderate exposures are those which are exposure to the non-intact skin with large volumes or percutaneous superficial exposure with the solid needles. Severe exposure is obviously it is like wide bore needles, because bore of the needle is important, as the HIV can survive for longer time in wider bore of the needle. If it is solid needle, obviously HIV will not be able to survive for longer duration of time. Then source code, it can be known HIV negative person, obviously if the tests have been done before. Low risk HIV positive but clinically asymptomatic, where we are saying or maybe the viral load is suppressed. High risk HIV positive with clinically symptomatic, or unknown. So status of unknown patient is unknown, and neither the patient, for example, there was a needle just lying down on the floor, and some janitor, he or she got the prick because of that needle. Now no one knows that what was the source of that needle. So in that case, again, it is labeled as unknown source. The risk assessment will be based on upon the type of exposure and HIV prevalence in the area. So it all depends on the HIV prevalence in the area. If prevalence is high, then PP is given. If prevalence is low, then PP is not given. So there is a flow chart we'll quickly come back to. For counseling for an informed consent, exposed persons should receive appropriate information about what PrEP is and risk and benefits of the PrEP. It should be clear that PP is not mandatory. The client should understand details of window period, baseline test, drugs that are used, their safety, efficacy, and all that, and drugs during pregnancy and breastfeeding. And he or she should be counseled on safe sexual practices till both baseline and 3 months HIV tests are found to be negative. Because window period is one thing which they need to understand very clearly, and effectiveness of PrEP. The time or when the PrEP should be given, that is very important, that it has to be the most effective way of giving the PEP or PEP is within the first 2 hours of the exposure. The effectiveness reduces over a period of time, and it is said that after 72 hours of the time it is actually no more effective. So obviously it is not the same that giving PEP at after 48 hours or so and giving within 2 hours. Obviously within 2 hours it is going to be much more effective, because when exposure happens before the virus is incorporated into the human DNA, if you are giving PEP, and also before the virus is actually goes into the reservoir sites, if you give much before that, then the PEP will be most effective. But what you should do if the person comes after 72 hours, that depends on the scenario. And some of the scenarios, if you are not able to convince people, we end up giving PEP to them. But it should be clear that effectiveness of the PEP declines as the time passes by. So you may have a lesser success rate, or it may not be effective at all after 72 hours. So this is how it is. It works: exposure code and patient code. So based on the these codes, actually the PEP, giving PEP or not is decided. So first is the source material is blood or bloody fluid potentially infected material, or in the instrument contaminated with these substances. If it is not infected, if you know that it is, for example, if suppose needle, someone bring it out just from the packet and it falls down, and with that needle if someone gets the prick, you know that here the instrument is not infectious, so PEP is not required at that point of time. But if you know that it is infectious, then the next question will be asked, that what type of exposure has occurred. So if it is just mucous membrane or skin integrity compromised, if it is low volume, it is exposure code 1, it is high volume, it is exposure code 2. If it is intact skin only, you see that if there is a contact with the blood but the skin is intact, there are no bruises, abrasions or anything, or nothing on the skin, then PEP is not required. And if percutaneous exposure, based on the severity, we will code that as exposure code 2 or 3. So when we decide for, and then it is source code. There are two codes which are decided, exposure code and source code. We just saw the exposure code. Now the source code is, if the source is HIV negative, known HIV negative, no PEP is required, and then status is unknown, then source code will be source code unknown. If HIV positive, then source code 1, source code 2, based on the CD4 or viral load these days. You can say source code 1, source code 2. So if there is exposure code is 1 and source code is 1, PEP is not given. Just to remind, exposure code 1 or is this, like low volume exposures to mucous membrane, even if the this is infectious fluid, and source code 1 is low titer and for example undetectable viral load or and very high CD4 and things like that, then it is not warranted. But if it is anything beyond that, is PEP is recommended. So it is given for 28 days. Now why 28 days is, again, there are very limited evidence on that. Some of the studies done in macaques, and they compare different time periods, and those who were given for 28 days, zero transmissions happened in them. Now these are the kinds of studies you cannot do on humans, obviously. So and that's how this 28 days comes in. But the first dose is also of the importance, that if you give that in first 2 hours or so, it actually reduces the risk of transmission by 80% by the first dose. That is why it is very important. And Dr. Dhani Reddy, she also spoke about the startup packs and all that. But completing 28 days is important but challenging. Many of the healthcare providers, they don't complete, the adherence is poor. Almost like 50% will drop out. And if source code is unknown, like unknown needle, and the exposure code is 2 or 3, then the consider PEP if HIV prevalence is high in the given population and risk categorization. So that is again up to the person who is deciding PEP to be given or not, based on all these factors. In case of sexual assault, whatever is the source, it is given. It is, as I said, has been included as a part of package. So only for rape victims, both in like men and women, so it can be given. Recommended baseline lab investigation in person taking PEP. Baseline can be HIV, HCV, anti-HBs antigen, complete blood count, and transaminases. And in person who is not taking PEP, HIV, HCV, and anti-HB can be done. Ideal time and duration we just spoke about. Within first 2 hours will be crucial. More than 72 hours, no one knows the benefit. There is little or no benefit after 72 hours. So the regimen which is used is in our program is tenofovir, lamivudine, and as 1 tablet in a day, and lopinavir ritonavir combination of 250 milligram, 2 tablets twice a day. So this is one thing which is new in the guideline. In the last guideline it had come, and 1 tablet immediately within 2 hours of accidental exposure, either at daytime or night time, and 2 tablets immediately within 2 hours of accidental exposure, either day or night time. So all these 3 tablets or 4 tablets need to be taken at a time. Next day 1 tablet once OD and continue for 4 weeks. Next day 2 tablets 2 tablets BD and continue over 4 weeks. So this is how it is given. And if lopinavir ritonavir is not available for some reason at some of the facilities, then TLE can still be given for 4 weeks. There is a question. If PEP has been started according to old guidelines, that is TLE, by the patient himself and taken only 2 days, and wants to start according to new guidelines, that is TL lopinavir ritonavir, then can be started or not? I think yes, if it can be started, it should not be a problem. As long as it is that continuity is maintained, it is good. But even if the person continues on TLE, it is okay. It should not be said that okay, this is better than that. That is why you don't use or use. Obviously, lopinavir ritonavir is, and in fact, the new guideline, if you see, not NACO guideline, but if you have heard Dr. Dhani Reddy saying that even the integrase inhibitors have been used as a third drug for PEP. So, just to answer your question, it can be started, but in my personal opinion, even if the person continues on TLE, it is fine. So the doses, zidovudine is as per body weight, per weight band for pediatric age group. Abacavir, if zidovudine is contraindicated, and efavirenz if lopinavir ritonavir is not available, as per weight band in children with age more than 3 years and weight more than 10 kg. So PEP after 72 hours, any change? PEP, if I have understood your question correctly, Dr. Yunus, I think PEP, what we said was within 2 hours if you take, it is most effective, and after 72 hours, if the first dose is started after 72 hours of exposure, then actually there may be very little or no use. The effectiveness actually reduces with the time of exposure. So as soon as possible after the exposure, PEP has to be started. So after 72 hours, it may not be of any use, but in some situations we actually end up prescribing PEP because of whatever reasons, pressure and anything. But if we scientifically, if we see after 72 hours, even in that comparative study in again monkeys, it was shown to be less effective, or may not be any effective after 72 hours of exposure. Clinical monitoring within 3 to 6 weeks after exposure, patients need to be monitored for seroconversion if suspected, refer to the ERT center, avoid blood donation, breastfeeding, pregnancy, and person should be using condoms for protection if they are sexually active, and adherence is again important. There can be some side effects of the drugs, you all know that, so I'll just skip this slide. If there is delay in reporting the exposure, expert opinion should be obtained. As I said, it may not be effective, but a person, if I am a medical officer sitting in some peripheral hospital where I do not have any access to any kind of like consultation, even though I can do that on phone and other means, but it all depends on the client. If someone insists, and if you are not in a position, because I don't want to mention, but there are some scenarios where you will face that pressure of giving PEP. So scientifically it doesn't work, but in some situations, if someone wants to have it, and in those situations you can still give. Unknown source, use of PEP is to be decided on case-to-case basis after considering the severity of exposure and epidemiologic likelihood of HIV transmission. Known or suspected pregnancy, do not delay PEP in initiation. Breastfeeding issues in exposed person, do not delay PEP. Source of the patient is on ART and has HIV resistance, then also it need to be consulted. For example, if you have a patient who is on second line ART, and then because of the needle which was used for that person, the another person who is HIV negative gets the exposure, or the blood of that person, the exposed person has, and where we know that source is resistant to a particular virus, or may be resistant to a particular, that is why the ART was changed from first line to second line. In that case, again, giving TLE may not be effective for those patients. PI based PEP will have to be given, and in fact that is the preferred PEP these days: tenofovir, lamivudine, and lopinavir ritonavir. But if the first line was suppose tenofovir lamivudine, and the second line is zidovudine, lamivudine, and lopinavir ritonavir, then this zidovudine, lamivudine, lopinavir ritonavir becomes the PEP for this particular client. So decisions like that will have to be taken by experts. So whenever you feel so, you please contact whichever expert you want to and get the opinion. Now for follow-up investigations, in week 2 and 4, complete blood count if the patient was started on zidovudine, but these days we are starting on tenofovir, so that may not be useful. At 6 weeks, that is 1.5 months, HIV antibody test need to be done. Week 12, after 3 months, again repeat test is done, and week 24, after 6 months, repeat test is done. It is important to remember that people who are exposed to the risk of transmission of HIV is also a risk of getting infected with HBV, and that is why I said HBV need to be given. We already saw that recapping is something which is really bad, so it should not be tried. That is the most common thing because of which people get exposure. Universal safety precautions should be used based on the risk of exposure and not based on the HIV positivity or negativity of the client, which is actually the practice in our sometimes when people ask me that if you are working with HIV positives, and don't you have high risk of HIV, and should it be like I've seen people who are using like gloves, and thankfully not in our ART center, but at least in the hospitals you might have seen that if the person is HIV positive, then no one even touches those patients without gloves, and they do all that crazy stuff. So I think so it's not about knowing the status and then using gloves or caps and mask and goggles and shoes and those things. You might have seen people using like double gloves, double masks, and goggles and everything, even for just blood withdrawal or like for HIV positives, they are using all these kinds of stuff. But if the person is unknown or HIV negative, they are okay with like doing even with one glove only and nothing else. So this is a wrong practice. Actually, those who are even HIV negative, they can be in window period. Those who are not known, they can be HIV positive as well. So it is actually not related to the status of the client. It should be related to the risk of exposure. So if I'm giving injection to someone, I don't even require glove. But if I'm applying an IV cannula, I have to have a glove. Double glove, I don't know how it works. It's actually doesn't work the way it is thought to work. So also, if I'm taking the blood out for sample collection, I have to use gloves. I may not be using like goggles at that time or mask at that time. But if I am going to conduct a delivery, I will have to have covered from head to toe with all these equipments. Like those are called as personal protective equipments or personal protective gears. So it depends on the procedure. So based on the procedure or risk of exposure, all these gears are selected, not based on the status, HIV status of the client. What about third line, that is raltegravir, darunavir, ritonavir? I would say if like I said, in those situations we have to contact the experts, and based on the scenarios we need to take the decision. But just to give the answer for that is like we will have to use RAL plus darunavir, ritonavir as post-exposure prophylaxis for those particular clients. If you know that the other drugs are resistant, ideally it is to be decided based on the line of treatment is to be decided based on the mutation patterns. But in absence of that, if you think that the drug which you are giving is already resistant, and if that virus has been exposed to this person, then the recipient of PEP should receive the same regimen as the person is on. So in this case is third line. So had some issues with audio. Can you please Praveen, can you help Dr. Jayachitra? Please repeat what is PEP regimen for exposed to resistant strains. Yeah, so as I was telling before, those who are on second line ART, if they were on tenofovir, lamivudine, efavirenz as first line, and second line is zidovudine, lamivudine, lopinavir, ritonavir, so PEP for them cannot be tenofovir, lamivudine, and lopinavir, ritonavir. So PEP for them should be zidovudine, lamivudine, and lopinavir, ritonavir, because we know that now the first line was resistant, and that is why it was changed. Obviously, we have that limitation of not knowing the resistant pattern, so we don't know what mutations are. So that is why whatever treatment we are prescribing to the known patient, if that patient is receiving second line, so for PP also the same second line will be used. If tooth particles of HIV positive, so I'm reading it correctly. If tooth particles of HIV positive patient went into dentist eye while grinding tooth of positive patient, then dentist should go for PEP or not. That will be too much of stretch, but I know that with dentists that this might happen. I would personally not recommend PrEP in those in that situation. First, because HIV, think about that practically also, that HIV will not be able to survive if someone is grinding the tooth and if it is becoming like a tooth particle. HIV requires actually a medium to survive. That is why HIV standalone cannot survive outside the body even more than few seconds. And but if HIV is in a blood bag, for example, if HIV positive donates a blood and there is a blood bag in which there is HIV, even if it is outside the body, it can stay for even days together, like 7 days or even more than that as well. So it depends on in which medium HIV is outside the body. In this scenario, specific scenario, what you just mentioned, I would personally not recommend PEP for that particular dentist. So just washing eye carefully with the method that whatever we saw should be enough for that client. So that's what our guidelines talks about. There are a few basics again about the prevention, and also we need to understand that why that 2 hours time we say that first dose need to be taken. This we had already discussed before, that this is HIV virus and these are dendritic cells or antigen presenting cells which take the HIV into the regional lymph nodes, then blood, and then it goes all around. So before HIV reaches the reservoir sites, if it is given, that is most effective. In fact, I would say that the most effective time is, if you remember that CD4 and HIV multiplication diagram, where we said that when it enters the body, when it enters the CD4 cell, the single stranded RNA gets converted into double stranded DNA, that is proviral DNA, and that is integrated into the human DNA to make that genetic change into the human DNA. If before this time, if PEP is given, I would say that is the most effective time. So that is why within 2 hours time, if it is given, once it gets incorporated into DNA, then there are chances that multiple copies are formed. Once copies are formed and once it goes into the blood, once it goes to the reservoir site, then I don't think it is possible to take it out from that site, even if whatever PEP we give. So the usual time for the HIV to reach the bloodstream through this way is like 5 to 11 days, within 11 days time. So that is after following the sexual exposures. But with percutaneous injuries and exposure like this, what we spoke about, like if exposure is severe, then you cannot wait for a long time. Immediately PEP need to be introduced. So longer the time, benefits of PP will go down. These are the slides from Dr. Dhani Reddy's presentation, where she mentioned about USPHS guidelines recommending raltegravir, or which is an integrase inhibitor, as a third drug for tenofovir after tenofovir emtricitabine. We mentioned about emtricitabine before also. It is very similar to lamivudine. In our program, we are using tenofovir, lamivudine, and lopinavir ritonavir. Duration is still the same. So as they are using raltegravir, it is okay. And these are the other options which can be used. Here you can still see usage of tenofovir, lamivudine, and here lopinavir ritonavir can still be given. Prevention of positives, as I was just mentioning, that these days we are giving ART to everyone, that all those who are HIV positives. So it was from this study which actually became the basis for our treat all policy, HPTN 052, where if you can see, even India was one of the site, especially Pune, Nari was one of the center for HPTN 052 trial. So in HPTN 052, what they tried to establish was the transmission after giving ART to those who are HIV positive in a discordant couple, and they reported like one linked transmission because of that particular person in early arm if you start ART early, versus if we start ART to those who have CD4 less than 350. So it was very strong basis for recommending treat all. So as there was 96% reduction in the infection. So early initiation of ART reduces rate of sexual transmission of HIV, and clinical events indicating both personal and public health benefits from such therapy. So in this partner study, they again reported zero linked transmission. Linked transmission means from that particular partner. So if at all the new person has got HIV, they just checked whether that HIV was from the partner or anyone else. So there was zero link transmission were reported. Even the opposite attract study, 350 serodiscordant couples, MSM couples, again zero link transmission. So there is very strong evidence to say that undetectable is equal to untransmissible, especially through the sexual route of transmission. Again, we are not so sure when we talk about other routes of transmission like drug use and all that, but for sexual route of transmission we are very sure. But even the drug injectors, they also have dual risk of they inject drugs and also they get indulged in high risk sexual behaviors. So in them also, because of this, if their viral load is undetectable, they are also not able to transmit HIV because of the sexual route. So I think that's the last slide. That was about pre-exposure, post-exposure prophylaxis and prevention. Under prevention, there are many things, but I would again say one thing, that one of the most crucial key point is if you are starting at ART in HIV positive, and if you are aiming at undetectable viral load in that particular client, that is the best way of prevention of HIV, I would say. So yeah, U is equal to U. Is it true for mother to child as well? That's a very good question. In fact, the same question was, I think, asked in the UW session also. There is no evidence to say that because all these evidences which I showed you, studies, that those were for sexual transmission of HIV. But we know for the fact that if that 30 to 40% risk of transmission from mother to child, it can be reduced like to less than 1% with the use of all these strategies of like starting ART early in the mother, good adherence of ART, and then the viral load becomes undetectable in mother. And we know that the most risky among the three stages of this, like during pregnancy, during labor, and through breastfeeding, the labor is the actually most risky time for this HIV conversion. So if the mother's viral load is undetectable, then before in the earlier pregnancy itself, the risk of transmission will be, I would say, less than 1%, but no one has said that U is equal to U in for mother to child transmission. I think by now you understand this, that whenever someone makes any statement like this, how do they make those statements? Let it be like working of PEP within 2 hours, not working of PEP after 72 hours, taking PEP for 28 days, U is equal to U. So all these are based on evidences and studies. Obviously, you cannot perform any study like this which can uh, uh, establish U is equal to U, where in mother to child transmission, where you will not be able to do any prospective studies like that because of obvious reasons. But whatever has happened after treat-all launch, if you study that, you can comfortably say that transmissions are not happening. Even in fact, we are at the verge of elimination of mother to child transmission of HIV these days. So I can quote JJ Hospital head of the department saying that, and even that was in the newspaper, that for the first 100 deliveries after the launch of Treat-all, there was zero positivity in the children born to those HIV positive mothers. So there is enough of the evidence that transmission risk is really low, but to say U is equal to U confidently in this particular group, I cannot say, or no one can say without any documented evidence. So I think you can, by now you understand that how the whole thing works out. Okay. Okay, so if there are no more questions, then I think we can sign off for today. So thank you very much for participating. One last question I can take: risk of HCV transmission through